Good afternoon, everyone, and welcome to the CDPH and CMA Virtual Grand Rounds. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's session on infectious diseases on the rise. I don't buy eggs very often, and so my mind was blown when I entered a store last week and saw the shelves completely empty. I know I'm a bit late to the party on that one, but again, we are seeing an emerging infectious disease impact our lives well beyond the clinic. And avian flu isn't the only hot topic on the infectious disease menu. And so we are so pleased that, as usual, we have the current California State epidemiologist, Dr. Erica Pan, here to help us understand the current pattern of infectious diseases like avian flu and others as they trend for this year, our first virtual Grand Rounds of 2025. But before we get started, a little housekeeping. I just wanted to let you know that we'll be hosting this series every other month this year as we work on the best cadence to bring you all the most up-to-date evidence-based information on emerging public health issues. And second, while our speaker remains the California State epidemiologist for the remainder of January, I'm thrilled to congratulate Dr. Pan on her new role. In February, Dr. Pan will transition to the role of Director and State Public Health Officer of CDPH. So soon to be Director Pan, thank you very much for being here, and I'll let you carry on after we quickly show you the disclosures. Here is our agenda for today. Next slide, please. As usual, we offer CME, so please make sure to fill out your form at the end that will come in tonight, and you will get your certificate. All right, Dr. Pan, thank you.
Great, thank you so much, and thanks. I see some of the virtual applause. Thank you all so much. Yes, I'm excited about this new opportunity, and just while we're mentioning that, a huge thanks to Dr. Tomas Aragon, who has been the Health Director and State Health Officer since early 2021, and it's really been an honor and a pleasure to work with him and to follow in his footsteps and build on his legacy. I also just wanted to acknowledge any of you in Southern California and what all of you are dealing with in LA and Pasadena and Southern California. Our department is also very active with our state operations center and working closely with LA County and Pasadena Public Health on trying to support all the different impacts that are both current and starting to think about forthcoming impacts of the fires. So just my thoughts are with all of you. I hope all of you and your loved ones are safe. And I know there's some challenges for patient care as well. And CMA actually already reached out and has proposed that we do grand rounds on impacts of wildfire, and we can certainly touch on trauma responsive care and mental health as well. So, we'll more stay tuned on that. For today, I'm still going to focus on the previous topic, which is other infectious disease updates. So with that, we can go to the next slide. So I'm going to really talk more broadly about respiratory season updates. We are certainly in the peak of flu right now. And then, of course, there's a lot going on with avian flu A and H5N1, and happy to give some updates on that as well. Wanted to touch on norovirus because, as we all know, we're seeing a lot of that as well. And then there was a recent, at the end of last year, a Clade 1 case in the Bay Area in California, and that was the first in the country as well. So I can touch on that briefly as well. Next slide. So respiratory season updates, next slide. So just want to kind of outline for you too how we think about and how we, get data from public health. And, there's this whole sort of triangular pyramid of what we look at. So starting, at the bottom with thinking about people who, don't even have symptoms or pre-symptomatic. And that's where wastewater has been really interesting and useful. And we'll touch on later too, and how it's also been useful to look at other environmental potential contributors to wastewater, especially related to H5. And then, of course, there's symptomatic and people who are tested. So either clinically attended or as they're increasing other opportunities for testing. But so like we did with COVID, we look at test positivity for other diseases as well. We are unique in California in that, or at least it's not a national requirement that all laboratory testing that is done with CLIA labs is required to be reported for flu A, RSV, and COVID, both negative and positive. And I'll talk a little bit more about how that helps us with flu A surveillance in general. And then, of course, there are some Sentinel sites, thanks to those of you that are part of our Sentinel sites that help us with either key areas or other key ways we keep our finger on the pulse of what's happening with respiratory viruses. And then, of course, emergency room, there are syndromic surveillance. There's a lot of variation in the state related to syndromic surveillance, and we're just finally launching kind of a statewide initiative with that, being able to access more of the syndromic surveillance and onboarding more hospitals. And then for hospitalizations, there is some Sentinel data, again, from some key partners. And then there is the National Healthcare Safety Network, which most of you may be familiar, was previously really focusing on healthcare-associated infections as far as reporting those. And then during the pandemic, we used that network to look at bed capacity, how many were also hospitalized with COVID-19. So that requirement restarted at the end of last year as well, and I can show you some of the data that we have on that too. And then, of course, looking at genomic surveillance really helps us see some of the details of what specific clades and genotypes or subtypes of viruses are circulating. And then, of course, looking at percent death due to disease. So we use all of these different resources to really help us, and there's obviously, of course, pros and cons to each of them. And some of these data pipelines for us are more or less robust as far as the state. Next slide. So with that in mind, this is a snapshot through January 4th, and this is on our respiratory virus website report that you can get weekly. We typically post these on Fridays, and sort of the bottom line on here is that flu activity is high, RSV activity is also moderate. COVID-19 activity is relatively low, although you'll see still causing a significant impact on hospitalizations. And we are seeing mostly flu A as opposed to comparing to flu B, and both H1 and H3 seasonal subtypes are circulating. And you can see that test positivity for flu is as high as 20% right now, although you'll see in some other graphics that it may have peaked. Of course, it'll be another few weeks before we really see consistent trends that we can look for. But that's sort of the highlights of those. And then I'll go through some other snapshots of some of this data too. So next slide. So what are we seeing in wastewater? So again, this is really was developed during COVID to look at, just overall what are people shedding that is not necessarily care seeking for testing. So with RSV, we actually have seen trends increasing over the last couple of weeks, and it's been up by 34% as far as looking at our statewide data. And then you can see here too that COVID actually is much lower right now than what we saw at sort of the end of the summer, early fall peak. But it is increasing right now over the last 3 weeks. We may see there if it will, have a decrease and then a bump again, if it's plateauing, or if it's, if we look at other seasons, it probably will eventually go up again, but probably later, since we had a later summer surge this past summer, fall. Next slide. And then flu is very interesting right now because of what's happening with H5 in California. So flu overall began to be really high in our wastewater and started increasing at the end of last year as we were seeing more H5 infected herds, and thus H5, our presumptions on a lot of this are that there's PCR positivity in pasteurized milk that can be dumped, and then also looking at some of the dairy processing plants where we're seeing H5. So you can see that a lot of the contributor towards the end of last year was actually H5, but now we're seeing flu A overall increasing and H5 is decreasing statewide, and you're seeing a little bit of flu B there as well. And then it looks like both H1 and H3 subtypes are increasing as far as circulating right now in California. Next slide. And then looking at test positivity, as mentioned, but just to kind of, again, highlight, looking at the trends that we're seeing, flu is the highest right now. And again, both based on wastewater and this test positivity data, we may have peaked. We might have, hit the peak of the season now, but we'll need to see another week or two to really see those trends. And then similarly, you can see that RSV is a little bit later this season than, especially compared to a couple of years ago when we had that very early peak, and may also be plateauing. And again, we'll have to continue to watch that. And then COVID looks like it's low, but may or may not be increasing as far as test positivity. Next slide. And then the CDC also looks at emergency room visits. So this is what you can see if you pull up on the CDC dashboard, and if you compare us geographically, we're at high levels of overall respiratory illness in California. And again, that's largely driven by flu, as you can see in these trends here. We are, again, still starting to really onboard a statewide syndromic surveillance system. So this is only representative of about 30% of emergency rooms. So just keep that in mind. And it does vary, again, quite a bit geographically in California. Next slide. And then hospitalizations. So this is really helpful to look at, and really reinforces trends we already know about as far as who's most impacted by these diseases. But certainly those over 75 years of age are the highest proportion of people who are being hospitalized for flu and COVID-19. And then also, not surprisingly, but you can see that for RSV, there's a much higher proportion in young children under 4 years of age. But you do see there a similar U-shaped curve that we often see with, the extremes of age as far as the hospitalizations for all three of these diseases. But again, most marked that RSV is higher hospitalization rates in the young children. So just keep this in mind as you're thinking about who you're testing for early treatment and other public health and medical interventions. Next slide. So also looking at hospitalization from the National Healthcare Safety Network that I mentioned. So there was a lull in this being required for all hospitals to report to the state and CMS. It resumed as of November 1st, and we are now starting to see that data in our system, and have been looking at that pipeline and cleaning it up. And again, similar to the other trends, flu is really what's driving hospitalizations right now in California, and seeing some increases in COVID and RSV here as well. And also of note that when we do compare to what we can see last season, flu is over double what it was around this time last year. And then COVID hospitalization rates are much lower than what we saw the same week of last season. We can't compare because RSV data was not required or part of our data set last year. So we can't say as much about that trend compared to last year. Next slide. So what are we forecasting for the rest of the season, and how does that compare to prior seasons? So this, again, is a nice comparison to look at 22, 23, 24, and now where we are here in 24-25 season. So, thankfully, again, the overall respiratory burden, especially if it has peaked, which it may have, seems to be lower than last two seasons. And we'll be interested to hear if that's sort of anecdotally what you all are experiencing on the ground, taking care of patients as well. And we do forecast a late RSV season, but you can see again that the largest proportion right now of what will come is RSV, and that we have a big proportion of flu right now. And then we're continuing to see what will happen with COVID as well. Next slide. And then as far as flu admissions forecasting, so this upper graph again shows a comparison to the 22-23 season when we had a very early flu season. And then last year, a later flu season, but a lower peak. And then you can see here our weekly flu admissions here are higher this year, but again, maybe plateauing, but higher this year than both of the last two seasons here. And some forecasts of sort of that plateau and how that drop may look. There's a lot of variation, again, regionally. I think the Bay Area right now is where we're seeing some of the highest numbers and may not quite have peaked, and then there's some variation across the regions. Next slide. So also wanted to share, this was just posted and circulated on Friday, the 10th. we have been able to update, and this is interim because the CDC is deferring to the HICPAC advisory committees for infection control, and there are some guidelines that they've been working on that haven't been updated for many, many years that are broad for healthcare-associated infections and healthcare infection control for multiple diseases, not even just respiratory viral infections. The last time California had updated our guidance, and we were really wanting to watch and see what the CDC was doing for COVID-19 healthcare worker exclusion guidance. And the last time we actually updated this was 2022. And what we had on our all facilities letters was that there would potentially be up to 10 days of work exclusion, depending on subsequent negative tests for healthcare workers who tested positive for COVID-19. So we have just posted this move to do what we've done with all of our other guidance related to COVID-19 and really thinking about it more coherently with all of our respiratory viruses. And these new interim guidelines are mirroring what was submitted by the advisory committee to the CDC on healthcare infection control. And we will see, over time what the CDC then adopts and can reassess then. But our interim guidelines in California are that regardless of whether testing is performed, so if there are respiratory virus illness and symptoms in your healthcare providers, that they should not return to work until 3 days have passed since onset. And of course, like we do currently with a lot of other flu and other illnesses, at least 24 hours with no fever and symptoms are improving, and they of course feel well enough to work. So this has shifted from, again, the potentially up to 10 days of work exclusion. There were some exceptions in our prior guidance if you had staffing shortages, but now this is not dependent on staffing shortages. And then if you have any asymptomatic workers that are that test positive but don't have symptoms, then again, it's about 3 days of exclusion since our first positive test is our guidance on this. And to wear a face mask for source control for at least 10 days after symptom onset or positive test. And we know many of you in the healthcare setting have during this respiratory virus season healthcare providers wearing masks anyway during the season, but this is just an added precaution if people are coming back post respiratory viruses to have that source control. So again, this is really not COVID-19 specific anymore and broader for respiratory viruses since many times workers and the public are not testing. Next slide. So just to kind of recap and summarize, flu seems to be this season similar to pre-pandemic flu levels. It did rise later this year than last year and may have peaked. We do seem to be seeing decreasing flu admissions as well. Although flu A seems to be declining, just a reminder that often what we see as far as sometimes a second peak in flu season is from flu B. So we'll keep our eyes out for that. And as you saw from a few of those different graphics about comparing to prior seasons, we are seeing a lower burden, thankfully, of respiratory viruses this year. And, we'll continue to watch. It's crazy to think that this is actually our 5th year since 2020 of experiencing COVID-19. And we do often, pretty much every year, we've seen some sort of spring or summer wave. We'll see if that will continue over time and continue to monitor. But it definitely seems to be a consistent pattern of a couple waves per year rather than just one respiratory virus season like we've been seeing with flu and RSV. Next slide. So I just wanted to remind you all too, and we did put out a press release about this at the beginning of the year, but pertussis is also returning to pre-pandemic levels. And like many other vaccine levels, we're seeing lower levels of vaccination as well, which I'll touch on in a bit. But infants are too young for vaccination, and as you all know, are greatest risk for life-threatening cases. We've had at least one infant death already in California. And a reminder to immunize your pregnant patients as well to prevent infant hospitalizations and deaths. So this is really the most important tool for preventing infant morbidity and mortality. And I'll show you a little bit more later when I focus on vaccines about where we are with pertussis vaccines. Next slide. So what are some of our immunization updates we wanted to highlight for you today? Next slide. So this is where we are with flu vaccine, COVID-19 vaccine, and RSV vaccine, including some data here on our highest risk individuals. And this is where I really want to appeal to all of you as providers, because your patients really listen to your advice on this. And we can see that for flu vaccine, only 43% of adults have gotten their flu vaccine as of early this year. This is our data as of, actually the US data is from January 3rd, and our California data is through the end of the year. And then, nationally, we're pretty similar for flu vaccine as far as adults 18 and over. We do think we have higher numbers of elderly adults who get their flu vaccine nationally, and I think when we do pull our California data, I anticipate it will be similar. So higher flu vaccination levels, but when you look at COVID-19 vaccine, only less than half of adults 65 and over nationally are getting COVID-19 vaccine, and only about a quarter of adults 18 and over are getting updated COVID-19 vaccine. So we really have work to do to improve our prevention of COVID-19 morbidity and mortality. And then we don't have California data yet on RSV vaccine in adults 75 and over, or our infants. But again, of those who are eligible, we're seeing less than half. So again, really want you all to work on, it's not too late. Yes, we are seeing maybe the peak of flu season right now. And, there is still flu circulating after the peak, and it's not too late to vaccinate especially your high risk patients. Next slide. So maternal RSV vaccination and nirsevimab, this was data from last April for infants less than 8 months. And this is another situation where less than half of infants who were eligible to get either their own antibody nirsevimab or maternal RSV vaccination actually received that benefit. So really, again, want to remind you every year to talk through with your pregnant patients and then certainly your new parents about being able to prevent for RSV. Next slide. So this survey, again, was last year between the end of March and early April, and the maternal RSV vaccine coverage was only about a third of eligible women got RSV vaccine during pregnancy to protect their infants. And then the nirsevimab coverage was less than half as well, and only about 56% of infants were covered by one or the other. And really importantly, and again, why we're appealing to all of you with this information is that nearly half of the women surveyed did not report that any provider recommended that either they get the vaccine when pregnant or that their infant get RSV immunization. I'm going to keep hammering it home, provider recommendations are associated with higher coverage for any vaccine, including RSV. Next slide. And here again are the top reasons that were reported for the pregnant woman not getting immunization, not getting that recommendation from a healthcare provider, and or not knowing were the two top ones. There are some concerns out there about safety risks, but again, the most common responses were about not getting the recommendation. And then there's a smaller, the third and fourth reasons are concerns about safety or not wanting to get vaccines during pregnancy. You will have all these slides, so I won't read every single one of these, but again, just reiterating, your recommendation is incredibly important. Next slide. And then for infants, there are potentially more concerns. The top reasons are more about concerns about the safety of an antibody shot, or not getting any vaccines for infants, or not getting too many vaccines for infants. So this is where I think, continue to work on vaccine confidence in general and vaccine information for parents, and certainly parents of young infants. Next slide. And then here's what we know about healthcare workers ourselves, and that we don't actually have great coverage anymore. And we had really high levels at certain points, both nationally and in California, of healthcare workers, including in acute care hospitals. But now we're actually under the national average from last season, at least, of healthcare workers getting vaccine against flu. And in nursing homes, in our highest risk setting, less than 60% in California of healthcare workers in nursing homes are vaccinated against flu. And even lower nationally. At least there we're higher than the national average. And then for COVID vaccine, you can see how low our numbers are. In California, in acute care hospitals, less than a quarter of healthcare providers are actually getting their up-to-date vaccines in the fall for COVID-19. And then in nursing homes, again, our highest risk population, where, as you all know, we're seeing the most deaths and the most hospitalizations, only 15% of those providers are getting vaccine for COVID-19. So please, please, please get yourselves vaccinated, get your staff vaccinated, and recommend it to your patients, your high-risk patients. Next slide. So just, this is basically the message I'm hammering, that everyone 6 months of age and older should get both COVID-19 and flu, and then remembering who's eligible as far as infants and pregnant persons and older adults for RSV immunizations, and that they absolutely can be co-administered at the same visit. We sent out a health alert in early October on this as well, as far as preparation. There's a lot of supplemental slides later that I won't go over, but that you can look at for nice graphics, social media, other materials to post in your office, and other great resources, other sort of cheat sheets for you on eligibility, because I know it's confusing, especially when it comes to things like RSV, but on who's eligible and what periods of time. So please look at those supplemental slides for more resources there. Next slide. And this is one of them. A lot of these resources are on our, what we call our easyIZ.org website. And again, you can see kind of a nice summary of all three of these big viruses and when they're recommended, and just, showing here we are in January and it is still time. So again, not too late to vaccinate actually for all three of these for high-risk individuals and everyone 6 months of age and older for COVID-19 and flu. But please, please, especially for those at highest risk, please be emphasizing that to your patients and making sure it's easy for them to access those vaccines. Next slide. So avian flu, I know there's a lot of interest and questions, and never a dull moment when it comes to avian flu in California lately. Next slide. So just to give you some updates on where we are with the animal infections in California, there are over 700 dairies that have actually been confirmed over those herds in California, and at least 100 of those have actually been released from quarantine. So this is the first time we've gotten into that triple-digit number that more of those herds have been infected and are have been released from quarantine. And what the California Department of Food and Ag does is they make them wait at least 60 days after the first infection, and then they have to test negative 3 times in a row before they release those herds and dairies from that quarantine. We did declare a state of emergency in California in mid-December because that was the first time we saw new herds in Southern California. So the biggest density and region where we have the most dairy herds in general is in the southern Central Valley, and across the San Joaquin Central Valley. And our Department of Food and Ag partners were really hoping to contain the herd infections to that region. And in mid-December is when we did detect a few herds in Southern California. So that was a lot of what the declaration of state of emergency was. It really helped us free up, and especially for our ag partners who really do a lot of the field work on the ground as far as issuing these quarantines, doing all that specimen testing and test collection from bulk tanks, to have more resources, more staff, more hours of staff, et cetera, to do all that on the ground work and lab testing as well. There have also been 58 commercial poultry flocks and 9 backyard flocks in California since September of last year. So our state had more experience with poultry flocks from 2022 and on, and then didn't have any earlier in 2024, but towards the end, as noted here, we have seen more commercial poultry flocks and backyard flocks. And there's been a mix as far as clade and genotypes of what kinds of infections those flocks have had. Many of them have had, especially in those regions near the herds, have had the same genotype of H5N1, and then some of them have had the genotype that's more associated with other wild birds. And the peak Pacific migratory pathway across sort of the Pacific coast is typically in the winter months. So that is where the thought is a lot of the source for some of those backyard flocks as well. Next slide. So as far as human cases, as of So there are 66 confirmed U.S. human cases in 2024. 23 of those were following poultry exposure. We have not had any human poultry worker cases or poultry exposure cases in California to date, and 40 have been following exposure to dairy cows. 36 of those have been in California, including one probable case that was positive at a state lab here and negative at the CDC. Often that can happen with low viral levels and specimen degradation by the time it gets to Atlanta. We now have our second child in California that was detected via enhanced surveillance. You may have seen the news on this in San Francisco. This was tested positive at a local public health lab in San Francisco. It will be tested at the CDC this week. But this is our second with a child with an unknown exposure in California. And then there was that case in Missouri also that had an unknown exposure source. All three of those were picked up with enhanced flu surveillance. This child is recovered, has had mild illness. Was not hospitalized, but we are San Francisco is investigating this, and we're working closely with the CDC on additional investigation and testing as well. And then you likely heard about the fatal case in Louisiana recently as well, in a individual who had backyard flocks. There may have been some wild bird exposures there too. That individual was elderly and had underlying conditions. A couple global things to just be aware of. You likely know as well about the teen in Canada who was in the intensive care unit and very, very ill, also without a known source. And then just this week, there's also been a report of a young adult in Cambodia who also has just recently, sadly, another fatality in Cambodia, also with caring for sick poultry and possibly eating poultry. More investigation and more information to come on that. So, we continue this surveillance, and to date, again, in California, most of these cases have been mild. Most of them have had a known exposure to infected animals, to infected dairy cows, but we just, are continuing to investigate more of these unknown sources and really want to know, what is this other source that we haven't quite determined where these are coming from. No human-to-human transmission has been detected in the United States, nor anywhere in the world since probably 2007. And in all of these cases, there is always investigation of close household contacts, testing if they have any symptoms, and there's not been any evidence of human-to-human transmission. Next slide. So I think I've covered some of this. Again, when you see the genotype B313, that is the one that's more associated with dairy cows and dairy workers. The fatal case in Louisiana had D1.1 genotype, which is more typically associated with wild bird exposures. And that is the same type that the teen in Canada also had. And I already emphasized no person-to-person spread. Next slide. So how else are we looking for H5N1? And, again, we've now found another case without a known source, kind of in backwards order here, but you can see this is sort of the regions and the locations where we have wastewater detection. We actually, over the last several months, have had detection of flu A and specifically H5 in most of our sewer sheds across the state, including in areas without dairy cows. Most of those areas that are outside of the dairy herd regions, many of them do have dairy processing plants. And then the other working hypotheses for most of these is that there is likely residential and or commercial milk dumping that goes into the wastewater systems and picking up H5 PCR positivity. Those levels I showed you in some earlier slides have been decreasing over the last several weeks for H5 specifically. So the burden of that even in presumably milk has decreased over the last several weeks. And then we do have 17 public health labs in California that can do H5 subtyping, and 2 commercial labs that the CDC has contracted with. There's another one that is intended to onboard soon, and I believe the CDC intends for 2 other commercial labs to get that testing available as well. We know at least one academic lab also is doing weekly H5 testing of their flu A specimens. And then we, again, in California, I started to mention this earlier, We require all clinical labs as well to submit their flu A tests and their subtypes. And it is interesting to know that about 10%, 9 to 10% of those labs are actually doing subtyping. So that is another way. And just a reminder that if you get a result from your lab or your patient that is not subtypable for seasonal flu, then that is when you should call your local health department, report that, and then get that specimen tested for H5, because that would be a flag for H5 or another novel influenza. But this is, helpful to us in California around knowing that about 10% of that flu A that we are subtyping to look for novel flu, and have so far only seen these 2 cases. Next slide. I also want to encourage all of you, especially those of you who are hospitalists, to consider if you have hospitalized cases in the ICU that are testing positive for flu A, to talk to your clinical lab about whether they can do subtyping. And if they can't, to submit those specimens to the public health labs for subtyping to, again, just enhance, to make sure we're not missing serious disease. Again, there are many mild illnesses we have detected in workers. There's a lot of animal infections out there, and workers have been exposed to that, and we have not seen severe cases in California, and just want to make sure we're continuing to test for that and look for that. So please, in all of your practices as well, make sure you're thinking about that in your hospitals, and working with your local health department to do subtyping if needed. Next slide. And then, of course, the other really interesting evolving learning we have about the impact of H5 on all of us, and we had a fall presentation talking about One Health and really thinking about food safety. So just to reiterate, we know that pasteurization has been a really important public health intervention over the years to really prevent bacterial infection, and we know that it does prevent viral infection as well. But there are raw dairy products that are produced in California, and we have had 2 raw dairy producers that have been detected positive and had recalls. Some of them also produce other things like raw cheese, raw butter, and kefir. We have seen in less than 60 days, viability tests come back from raw cheese that had been contaminated. We're waiting to see more results of that moving forward. We haven't had any confirmed human illnesses. We've had early on with some of these recalls, some reports of illness. Some didn't have flu A at all. Some had flu A, but then it was subtyped to be seasonal. We had one pediatric case you may remember hearing about last fall who definitely consumed contaminated milk and tested positive for flu A, but did not have enough viral load or viral detection to see if that was seasonal flu or the H5 flu. And then we've also had 2 different raw pet foods recalled and testing positive for contamination. And in my next slide, I'll show you a little bit more about the feline illnesses and deaths reported. So bottom line here is to continue to educate your patients about consuming pasteurized products, and to not feed their pets actually these raw dairy products or even raw pet food. Next slide. So what do we know about felines in California? And just to mention too that, nationally, as there were other herds infected in other states, there was frequent mention of barn cats actually becoming infected and having fatalities. There are some unique neurologic impacts of H5N1 in cats, and they seem to have receptors in their neurological system. So it often can look like rabies, actually. So you likely saw some media and press about 7 affected cats in LA County. Santa Barbara has also reported 2 domestic cats from 2 different households. We've had, a couple other domestic cats in San Bernardino and Tulare. And then there were actually 6 different exotic or large cats in Northern California as well that have died from H5N1. So again, cats, both domestic small cats and large cats, do seem to have a predisposition to serious disease. And I think there's a lot of investigation happening as far as some of these exotic large cats. This has also happened in other states. There have been some links to turkey flocks from another state with raw pet food from Oregon, and a lot of ongoing interesting investigation happening in this space as well. Next slide. And then there's been a little bit of media attention calling our three big viruses and norovirus a quaddemic this year. And norovirus has been on the rise. So it typically does peak around this time as well, between November and April. And we have definitely seen some increased activity high in California since late October of norovirus. And then, of course, several outbreaks have been reported in California as well, including some norovirus outbreaks associated with the consumption of raw oysters. Next slide. And really just a reminder on this, that norovirus is not only extremely contagious and can be transmitted both person to person or through consuming contaminated food, and it really is not killed by alcohol hand sanitizer. You really have to do vigorous hand washing with soap and water. And this is how this really can be such a persistent outbreak within congregate living settings. Of course, people have heard about cruise ships with norovirus outbreaks, and even, hiking trails where there can be fomite transmission in areas like restrooms and other areas, because it can survive for weeks on surfaces and it's resistant to most non-bleach cleaning solutions. So it's a very resistant virus in the environment, and that's why it can be associated with such serious outbreaks. If you are seeing patients that are potentially part of an outbreak, please do collect stool samples for testing. And it really helps to get those specimens to help do that outbreak investigation and help do those extra aggressive interventions to help prevent further disease, especially again in these higher risk settings like skilled nursing facilities, assisted living facilities, etc. We have a lot of resources for this as well on our norovirus website, so you can look there, and I believe we might have included some in our supplemental slides as well. Next slide. And then this is just to kind of show you our different regions and how we've had peaks towards the end of last year of norovirus in all of our regions, essentially in California. And it looked like maybe in our northern rural area, although we have fewer wastewater sites there, that it was peaking earlier and had decreased, but may or may not be increasing again. And then, hoping to see in some of our other regions that maybe this has already peaked and is on the decrease, but something else we're continuing to watch as well. Next slide. So finally, I want to talk a little bit about Mpox, since we didn't have time, I think, last fall to cover this. Next slide. So just a reminder as far as clade 2, which is the clade we saw in 2022 when we had our initial emergence of Mpox in the United States and in California. This is still continuing to circulate at low levels in California. We have about 10 cases per week over the last year, and you can see there were some peaks maybe in the late summer, fall, and then potentially some decreases. And a reminder again that we have a vaccine for this, and it is now commercially available. Individuals do need to have 2 doses of Jynneos vaccine to prevent disease and severe outcomes. Next slide. And then in November, we had our first clade 1 Mpox infection in the United States here in California. So this was in a traveler who returned from Eastern Africa, where they have been seeing this clade 1 infections. And this case was isolated at home, recovered with routine supportive care. Over 80 potential contacts were investigated, all had very low risk exposures, extensive public health response, and no secondary infections were identified. The household contact did get post-exposure vaccine, and there's no current evidence of community transmission of clade 1 in the US, but we do anticipate sporadic travel-associated cases, and there is ongoing learning about this clade compared to clade 2. It may be more infectious, and early reports share that it could have more severe infections in clade 2. There's some subtypes as well of 1A and 1B, and what has been seen in Eastern Africa is largely the more severe infections that are more transmissible, and this has been seen in many other countries outside of Eastern Africa as well. Next slide. actually, and here's the highlights of that and of the map of where. So there have been 12 countries outside of Africa that have had these travel-associated cases. You can see the list here. In addition to here in the US and Canada and North America, many areas in Europe, and then Thailand and India as well, and China have all reported travel-associated cases. And then there was a secondary case where a France individual had contact with someone who had traveled to Africa. So that individual hadn't traveled, but was a secondary transmission. There have also been some countries with cases with travel to the United Arab Emirates, but they have not reported a 1B case. And then there has been household transmission in the UK, Germany, and China. So again, this is skin-to-skin contact, can be sexual contact. But just to make sure people are thinking about it. The other interesting thing about some of these cases is it can start with like an inguinal lymphadenopathy before those really classic pox-like lesions. So just keep that in mind if you're seeing inguinal infections, really asking about travel and other high-risk exposures. Next slide. And then we did send out a health advisory in mid-November when this clade 1 case occurred. And just a reminder of what I just said, to suspect if there's international travel or sexual or close contact with someone who recently traveled, especially to Central or Eastern Africa. And then the testing basically can be done at many clinical sites now where, and some of them will do where they look for orthopox virus, the non-smallpox type. And then if that's positive and clade 2 negative, then it can be sent for clade 1 testing. Follow infection prevention and control recommendations, and of course notify your local health department immediately if you suspect clade 1 mpox. And then those specimens can be sent to our state viral lab here in Richmond for expedited clade-specific testing. Next slide. And, vaccinate, vaccinate, vaccinate. Make sure that your patients who might be at high risk for either clade of mpox, and especially your HIV infected patients or any who have other immunocompromised, less than half of the people of Californians who are eligible have received both doses of Jynneos vaccine. So really, please make this part of your routine care, your routine sexual health care. And then there's a new recommendation for travelers of any gender or sexual orientation who might be going to countries that have ongoing spread of clade 1 to also get pre-travel vaccination. Next slide. And then as far as treatment updates, there are 2 clinical trials that have been ongoing. And we're learning that the most important thing as far as treatment for mpox is supportive clinical, just supportive care. Those who don't have severe disease or risk for severe disease like HIV or other severe immunocompromise typically recover with appropriate supportive care and pain management. There have been, in pediatric cases in Central and Eastern Africa, there's been much higher severity. But in these clinical trials, and including one of them with clade 1 in the DRC, the supportive medical care was actually the most important treatment, and that the antiviral did not necessarily reduce pain or time to lesion resolution. So the treatment, TPOXX treatment, is still available under an expanded access IND protocol for compassionate use in eligible patients. So again, if they have or are at risk for severe disease, including HIV infected with severe immunocompromise. Next slide. And I just want to acknowledge there are many people that contributed to all of this information on slides. This is just sort of scratching the surface of those, but wanted to thank a lot of our doctors and Michelle Leishman, who helps also pulled all these together and synthesized these, and many others who've helped contribute to all of these important epidemiology and the slides themselves. Next slide. And with that, I think we can stop for questions. Thank you.
Thanks so much, Erica. I just have to say how wonderful it is to have you for our whole time. I love all of our other speakers, but this is great to have you be able to dive in deeply this week. So thank you for that. As usual, we have plenty of questions and we'll get to as many as we can. One question was, people really just want to make sure they understand, and I want to make sure I understood and heard, and maybe you can elaborate on how folks test for H5N1. So So I heard you say if you get a flu that's not subtypable for seasonal flu, call your local public health department. So it's sort of, if you're worried about it at all, is your local public health department the first place to turn?
Yeah, and just sort of a reminder that H5N1 is flu A. And so, the combination of looking for, certainly, especially those of you that work in more agricultural communities, if you have workers or people who are working with not only dairy cows at this point, but also wild bird handlers. We've expanded a lot of our outreach to, zoos. Vet techs, especially with the newer infections in domestic felines. But yes, so as far as testing, many of these panels at these clinical labs can actually do subtyping. Sorry, and then and that can let us know, and it also helps us know what's circulating. Also, if we have a good match for a flu vaccine. And then if you don't find H1 or H3, then that's really concerning that this could be H5 or a different novel flu. And that can be done at the local health department or to those commercial labs I mentioned.
Yeah, okay. And speaking of vaccines, do we have information on how the circulating strands right now are responding to our vaccines this year?
As I was saying that out loud, I realized we didn't have a slide on that, and I haven't seen. I'll have to get back to people on how well the match is, and we'll certainly have a lot of good data after the last couple of weeks, I think, since we have seen really a peak of flu in the last few weeks. So more to come on that.
Great. I always ask you to make guesses into the future. I'm not going to do that today, Eric. I'm letting you off the hook-ish. I'm not going to ask you how worried are you about a big H5N1 massive, scary outbreak. But I do think it's an interesting question that folks have asked about. Since we have the capacity to make flu vaccines pretty easily, is that if there is a big H5N1 outbreak, is that going to be a protective factor for society as a whole? How quickly can we do that in general, et cetera?
Yeah, I think a couple things on that note. To also note that oseltamivir is an effective antiviral, actually, and some of the other antivirals are effective for treatment. So as we look and monitor for mutations in these clinical cases, both, especially in humans, of course, but there's a lot of good kind of, and it's helped a lot of the investigations to look at what genotypes and the whole genome sequencing of the animals too. So treatment is effective currently, and we're watching for any mutations for that. There was one of our California cases that had whole genome sequencing that had a mutation that might make it resistant to banoxavir, but not necessarily oseltamivir. And a reminder that there are multiple antivirals for flu. And then for vaccine, yes. So the federal government has produced at least 5 million doses of H5N1 specific vaccine. And my understanding is, and hopefully this will continue, that their plan is to have another 5 million or so doubling that by this spring. So they have that in there. And so far, as far as monitoring the whole genome sequencing and the genotypes, those also look like they would be a good match for that vaccine. So yes, it should be much, much easier. It's not a whole new virus like we had in 2020 where we had to have new technology, new viruses. It's more like 2009, if people remember, and we're practicing then, we did have that H1N1 pandemic vaccine in people's arms, within a few months after the first detection. So, and this time we actually already have some. And I do think, yeah, so yes, that's also reassuring and different than thinking about, I know many of us are, we're all still just recovering still from the COVID-19 pandemic. And I do think we have a lot more tools for this virus if this does evolve to be more adaptable to mammals and humans or human-human transmission.
Okay, wonderful. Another quick vaccine question is there was maybe promise of a combined COVID flu vaccine. Are you hearing about that? Coming anytime soon?
I don't have the updates on that, but I can definitely ask our immunization team more about that.
Okay, great. Moving to a slightly different infectious disease that you didn't mention today, I don't think, is human metapneumovirus. Now, as pediatricians, we know this is the second or a very common cause of non-RSV bronchiolitis. So we're familiar with this. Is this outbreak that we're reading about in China different than the HMPV that we know and love here, or anything we should know about it?
Yeah, I have definitely been sort of monitoring and following that closely. And as far as I know, it is very similar to human metapneumovirus here as well. I don't know how long actually China has actually been testing, like how many seasons they've done more testing, et cetera, but monitoring that closely. And I've heard mixed reports about if the level of disease is actually even higher than prior seasons or not versus some other concerns. So so far, I've not heard anything concerning that is different or unique or causing more serious disease than as you just mentioned, being very similar to RSV bronchiolitis.
Okay, wonderful. That's good news. Okay, on COVID, we had a question about ongoing rapid test reliability for the new variants and subvariants as they come out. Is there data on that's changed?
That one I have not heard of any concerns, but I have not stayed as up to date on it either. But as far as I know, the current antigen testing should be similar for the currently circulating variants. All of the currently circulating variants have still been, some generations of basically that original Omicron. And that the the part of the virus that the antigen is testing for, as far as I know, has not changed significantly.
Okay. You talked about masking in patients and healthcare workers in general and the 10-day mask recommendation for folks who have been sick with any respiratory illness. One of our attendees talked about something that I don't know about, but apparently Santa Clara County may have some sort of requirement or recommendation that folks in outpatient and inpatient settings wear good fitting masks throughout the winter season. Are there any conversations broadly about that? What do you think about that recommendation extending it more broadly?
Sure. I think there are several jurisdictions and several health systems that have some different rules and acknowledging that. So, yes, some health jurisdictions have at the public health department level issued sort of requirements in healthcare settings, and there have been some variations, as I understand it. And I think we are thinking a lot about, for next season, are there kind of key metrics we could look at that could provide some more guidance for more consistency? Because we understand and know that, many of your health systems are across multiple jurisdictions, or it's just helpful to have a little bit more consistency. I think there was a lot of change in sort of our data pipelines and other things this past fall. But I think the bottom line is masks can absolutely be protective, right? It's another harm reduction method. And, the better the fit and the better, people are wearing it, that can be helpful. I mean, I think just speaking personally, I was coming back from winter vacation and hearing about so many people both looking at our data and hearing anecdotally about so many ill people. I decided to wear a mask on the plane because I just didn't want to be sick when I got back and came back to work. So yes, I think we have gotten some requests from healthcare systems, and we'll relook at this for next sort of winter season. And I have seen and heard some other Western states thinking about, different guidelines around that or recommendations. So we'll relook at that for the future as far as recommendations. It would certainly be a recommendation, but at least allow some consistency.
Yeah, great. Great. Well, I think that's all the time we have for questions today. I do want to loop back to two things you said, which is, of course, to really echo your thanks to Dr. Tomas Aragon, who's done a wonderful job in this position. We know him well as he is a San Francisco friend and doctor and supporter and longtime CMA supporter. So thank you to Dr. Aragon. I also want to extend my personal thoughts and sort of healing thoughts to all of those folks in Southern California who are so deeply affected by this crisis. And so sending lots of virtual hearts down to the south from where I am. And Erica, thank you so much, as always, for presenting our content. We can't tell you how grateful we are to have had you so many times over the past few years. For those who are watching, I just want to note that CME Professionals Day, a brand new holiday, is on January 24th. And we can't thank enough the people behind the scenes who make this happen. They do all of the logistics. They make it easy for us. And they do that important thing of making sure that all of you can continue the education that you need and to document it for continued work and licensing. So big shout outs to any CME professional this month, all year long, and particularly on January 24th. We are moving to that bi-monthly format. Right now, March 11th is planning to be a discussion of long COVID. Things evolve so much, both in fire safety and in infectious diseases. I'm not going to make a promise about what it is, or even that we won't have an urgent one between now and then, but please do join us anytime we send this out. And you will receive that survey at 5 p.m. today to get your CMA. So please do complete it at your leisure, and we will send you your certificates. Thanks again, everyone. Happy New Year.
Happy New Year. Thank you.